60% of the interventions are PDA device closure. When small PDAs often close spontaneously in many children, especially in preterm and neonates, large PDAs in small children may not close, and it may cause heart failure or pulmonary hypertension. And in young infants, it may cause feeding difficulties, therefore failure to thrive. So in borderline cases, the PDA with severe pulmonary hypertension, PDA closure is tolerated well by the patient even if there is some bidirectional shunt due to pulmonary hypertension. Explanation is not clear, but it has been observed that there is goes in many directions from the aorta, like through the PDA, through the neck vessels, and through the descending aorta. So there is division of the pressure load in many parts. So this may be the cause of less impact in the pulmonary artery tree and that of the ASDO PDA when there is right ventricle pump whole blood into the pulmonary artery. So what are the challenges doing large PDA in small infants? Performing a large PDA in small infants has some challenges like weight of the patient and vessel size. You know that we need to customize the hardware to cross through the small vessels of the small baby, so you have to tailor it accordingly. And anatomy of the ductus in small infants, especially those whose body weight is less than 5 kg, we have seen that mostly they have type B and type C ductus. And they have hemodynamic instability as well, like heart failure and others. And risk of complications like bleeding, infection, injury to the surrounding structures are also high. And the team needed technical expertise as well. And post-operative care, they need care of the puncture site, care of the pulse loss, and also monitoring of the vitals always in the post-operative period. So addressing the challenges of performing a large PDA in a small infant, combination of advanced technique, meticulous planning, and close collaboration among team members is mandatory. And these are the devices which we usually use for the closing PDAs in small children. So I will show you some of the cases. First case is 8-month-old, 4 kg, and this is the PDA you are seeing here, about 6 mm inside, and X-ray you are seeing also. And this is the aortogram showing a large tubular PDA, and we close these with an MFO device. We take the weight and angiogram as the pulmonary pressure was suprasystemic. So this is the patient after the procedure. This is the case 2, 5 kg, and 1 year old. And he has mild coarctation also, so we tried to close first, and the patient developed even cardiac arrest while we were crossing through the PDA. And we tried to place an NDO device first, but it came out. And we changed the device, taken a softer one, and then we were able to close this with the MFO device. But after that, the patient developed coarctation of aorta and LV stenosis in mild form, and we negotiated with the balloon and we sorted those, and there was no LV stenosis and coarctation at the end of the procedure. This is another case, 6-month-old, 5 kg. Again, there is a large tubular PDA, cardiomegaly and heart failure, and this is the PDA you are seeing in the aortogram. And something happened. We observed that something is moving towards into the right pulmonary artery, and we found that this is the peeling of the small part of the pneuma wire. So we were trying to take that out, but wherever we were touching with the snare, it was breaking there. So we stopped that, and then we closed the PDA with the 10/8 device. There was no coarctation, as it is a very small, large device for a small baby. So this is the patient after the procedure. Another patient, 5-month-old, 5 kg. You are seeing the PDA again is very large, about 7 mm, and this is in the aortogram. And we close this with the 10/8 device, but we assume that there will be jumping of the device towards the descending aorta. So we release the device in balloon-assisted technique. And this is the echo after the procedure. This is another patient with huge PDA with some coarctation and aortic stenosis. And then we could not see any flow in the aortogram as there was right to left shunt, so we measured the PDA with the balloon, and then we placed the device. It was almost like same pressure in the pulmonary and the aorta, and we later closed this PDA with 10 by 8 device. No, it is 12 by 10 device. So when assume that there may be coagulation and this is a very small baby, we observe the patient before releasing the device for 30 minutes for any pulmonary hypertensive crisis and then we release. This is another patient. You are seeing that there is a very large PD in the aortogram, and this one we closed with the 10 by 8 device later. There was no obstruction and in the LPA and also in the aortic side. This is another patient. The last one is 1 year and 2 months old, 4 kilogram, and this one has a large tubular PD also. This is a very large device, 14 by 12, but we checked the left pulmonary artery side and also the aortic side, and there was no coagulation. So we have a small study from 2 years in 2 hospitals. About 2,000 cases of PD was seen in this period, and out of them 680 cases were accepted for the device closure, and approaches were like this: femoral artery, vena, snare assisted, and balloon assisted. This is the snare assisted where it was difficult to cross, and this is the balloon assisted where then we jump of the device towards the aorta. And in age distribution, we are seeing that 3 to 6 is 47%. Females are more than the male, and in body weight 3 to 5 kilogram is the maximum, and according to the diameter more than 6 millimeter is the maximum. And pulmonary hypertension was severe in almost all of the cases, and most commonly used device was the ADO1, and there were some associated symptoms also, and